Welcome, Dr. Ramamurthy sir, for your presentation. So he is the most dynamic and the most knowledgeable doctor that ophthalmologist that we have seen, and especially in the last COVID times, in all the webinars he has been on our expert panel and given us pearls of wisdom. So looking forward to your talk, sir.
Thank you so much, Dr. Anaga, for this nice introduction. The topic given to me is getting the best out of your toric intraocular lenses. I'm going to just give you about 6 pearls in the next 6 or 7 minutes. Do not go use the refractive astigmatism, because there could be a lenticular astigmatism which could contribute to it. Another important pearl is that refraction may underestimate the true keratometric astigmatism. Look at this case, you do not really need an eye trace to do toric intraocular lenses. But just for an example, this is from the internal optics of the eye, this is from the cornea, this is from the internal optics. Almost the entire astigmatism that is there in this particular eye is from the internal optics. And once when you do a cataract surgery, obviously the cornea is quite pristine and there is no cylinder that's needed. So obviously you do not go by the cylinder on the spectacle lenses. This is the kind of variation that you could have, that almost a 1.5 diopters a cylinder completely goes away once the lens is removed. On the other hand, there can be a situation like this also, where the lenticular astigmatism and the corneal astigmatism almost neutralize each other, because of which the patient is not having any cylinder on the glasses. But once the lens is out, almost a diopter and a quarter of astigmatism becomes manifest, and hence a toric intraocular lens might be a consideration. So don't go just by the spectacle refraction as far as consideration for toric intraocular lenses is concerned. Use the right instrument and formula for the biometry. My favorite is the Barrett Universal 2 formula. Most often we go on to the Barrett toric calculator to decide whether the patient needs a toric intraocular lens or not. And based on that, we go ahead and counsel the patient for toric monofocals, toric multifocals, or just a plain monofocal implant. And it's not just the availability, the access to the right formula. It's also important that you invest in the right kind of optical biometer. There are several different options available. All of them we have experience with, and all of them work quite well in different centers once you understand them. And just in case you do not have access to even one of them, what is this? Sorry, I'm sorry. Just in case you do not have access to one of them, even if you are using a conventional immersion A scan along with a keratometric reading, still you can go on to the ACRS, APACRS websites, and you can access this IOL formula, which is available right in the front page of the websites, and you can get the benefits of using this formula. And I find that even in centers where we do not have an optical biometer, we use this formula, giving excellent results as far as the final intraocular lens power calculation is concerned. And especially if you are implanting a multifocal intraocular lens, it's important that you take care of even small amounts of cylinder. This is a time in which just then the trifocal PanOptics has come into being. This is a patient with a plus 0.87 diopters of with the rule against the rule astigmatism. We went ahead, PanOptics toric was not available at that time. We went ahead and implanted a plain PanOptics lens, and what we found was that the patient had excellent near vision, but was quite unhappy for the distant vision, requiring a mixed astigmatism glasses, and had an uncorrected visual acuity of 612. So we actually counseled the patient that we will take him up for laser vision correction 3 months later. But while waiting, he decided to go ahead with the second eye surgery. And in this case, we went ahead and had a look at the toric calculator. And for almost a similar amount of astigmatism, the patient required a T3 multifocal intraocular lens, and that's exactly what he got, ending up in the left eye, as you can see over here, a 6.6 N6 near vision, as well as a distance and near vision, as well as excellent intermediate vision. So we took up the first eye, which had received a plain multifocal intraocular lens, for a laser vision correction subsequently. So the importance of dealing with astigmatism, especially if you are contemplating a trifocal or multifocal intraocular lens, cannot be overemphasized. You also have to understand that with the rule astigmatism and against the rule astigmatism are entirely two different animals, and they have to be dealt with accordingly. For example, this is a case of against the rule astigmatism, and what you find is that for about less than a diopter of astigmatism, the patient actually requires a T4 intraocular lens. On the other hand, if you have a with the rule astigmatism of almost 0.75 diopter lenses, astigmatism, still it's a non-toric intraocular lens that is required. So the reason I am emphasizing it is often I am asked what is the power beyond which you consider a toric intraocular lenses. It's not an exact number. It also depends upon whether it's with the rule and against the rule. The best thing is to go ahead and feed it into your toric calculator and see what exactly is the power that it throws up and go by that. And well, another most important aspect that you need to understand is that for a sub 2.4 millimeter temporal clear corneal incision, the surgically induced astigmatism is just about 0.1 diopter. We have understood now that the astigmatism induced by any surgical incision has both a direction and magnitude. They tend to neutralize each other, because of which the centroid value of the astigmatism induced is just about 0.1 diopter. For a long time, I used to consider that my 2.2 millimeter temporal clear corneal incision induces 0.4 diopters of astigmatism. Now that concept has completely gone away. We no longer calculate our surgically induced astigmatism. If you are doing a 2.8 millimeter incision, it might be in the range of about 2.25 diopters. But if it is, say, if it's 2.4 or less, it's just about 0.1 diopter. The final tip is that you owe it to yourself and your patients to correct whatever residual astigmatism adequately and appropriately. For this, again, Barrett comes to your help with the Barrett RX formula, which tells you what exactly is the best modality for that particular patient. For example, this is a case where I implanted a 24 diopter T4 lens, and this is what the patient had as a residual error, +1 with 2.5 diopters of cylinder. Mind you, rotation of the lens will work only if the spherical equivalent of the residual refractive error is almost zero, like in this particular case. If just a plain cylinder or a plain sphere, just rotation of the lens is not going to play any role. So in that case, you might have to do a piggyback lens or a exchange of the lens. Here, in case you are exchanging the lens or are doing a piggyback, again this formula helps you with the actual calculation that is needed. Thank you so much for your kind attention.
Thank you so much, sir. Sir, do you believe that the total keratometry which is being used by in IOL Master 700 has better results than Barrett Toric calculator?
Yeah, in the sense that, as far as toric intraocular lenses are shown concerned, Barrett himself has shown that with the Barrett TK formula, Barrett 2K TK and Barrett TK toric formula, the results are slightly better. But in case you are doing in a post-refractive surgery scenario where there is a relationship between the anterior cornea and posterior cornea is disturbed, in that case actually measuring using a TK would be a good idea. But otherwise, in the run-of-the-mill garden variety of cases, it may not be very important whether you use a Barrett formula or a Barrett TK formula.
Yeah. And there was a recent paper from Savini in which he showed that even the total corneal refractive power compared with the Barrett Toric had similar results.
That's correct.
So I think Barrett Toric, as you also mentioned, it's an amazing formula and it's a very
Absolutely.
nice. Yeah.
Absolutely.
Any questions? And how do you compare the manual versus the digital marking system used for toric alignment? Do you find any?
If you have access to a digital marking system like a Varion or a Callisto, nothing like it, because there's automatic compensation for cyclotorsion, vagaries of marking is not there. But having said that, it's not that you can do toric intraocular lenses only if you have access to this. There are various ways of freehand marking using a bubble marker or even on the slit lamp with the pupil undilated with the slit splitting the pupil. Whatever you are comfortable with. I have done live surgery in different centers. Each center they use a different kind of marking. They are comfortable with that. Whatever you have mastered, whatever you are comfortable with, I think that's the way to go. But of course, if you can afford it and you have access to it, nothing like a digital marker.
Any other questions?
So your thoughts on multiple measurements and multiple instruments for getting accurate key?
Yeah.
Well, that's I mean, sometimes when you get multiple measurements, it becomes confusing. But there is another Barrett formula which says that you can input measurements from 3 different instruments. That is, you can take maybe from a pentacam, from IOL master, from a simple keratometer, feed all these 3 inside, and then what happens is this has the ability to throw out the outliers and just take the median. And when the median is taken into consideration, what Barrett says is 92% of his cases end up getting less than 0.5 diopters residual astigmatism. So maybe if you are getting multiple measurements and they are slightly differing, you can resort to this kind of a formula.
Let's just add a small point to this further. When we started measuring the K with 5 or 6 different instruments, we got such a wide variety of Ks that we really wondered whether we are on the right track. So
True.
till we realized that the problem was not that much in the machines, it was in problem in how we place the head in a choir. So the placement has to be such that the machine should move from one eye to the other eye, pupil center to pupil center. And at that point, when you start acquiring, your results come down to a level of 5-6 degrees between machines. And whenever we do a toric calculation, we pick up the two most reliable systems and then ensure that the difference is not more than 3 degrees. If it is not 3 degrees, we ask them to do it again. Repeat, repeat, repeat till you are within 3 degrees. And then we use that value.
I quite agree with you. You know, there's really not much sense in, unless it's an irregular cornea or something, doing in multiple instruments. Whatever equipment you have understood well, and especially if it's an optical biometer, they have fairly repeatable K readings as well as axial length measurements. You can go with that.
And how early would you like to rotate the toric IOL?
Normally wait
post-
for about 2 weeks time, you know, in the sense that if it's grossly not in
Yeah.
position on the first day itself, I find that it's 20 degrees off, I would take up the patient on the first day. But if not, otherwise it's been said that you wait for a period of 2 weeks till the capsule slightly contracts, and when you rotate the lens back into position, it will stay right there. So 2 weeks seems to be a sweet spot as far as, and the refractive error also stabilizes, you know, whatever residual error that is there, and that's the time period when rotation of the lens might be most optimal.
Right.
Thank you, sir.
Thank you very much, sir.